If you enjoyed podcasts like this, you should check out our other shows on Health Podcast Network. For example, Women Physicians Lead, hosted by Dr. Lisa Herbert, helps women physicians move from surviving to thriving in their personal and professional lives. Dr. Lisa shares leadership tips, burnout support, stress management strategies, and inspiration from women physicians who've made remarkable transitions into leadership roles. There's a fantastic episode that you should check out called Taking Care of Yourself During the Journey, about how women physicians can care for themselves while on their leadership journeys. Check out Women Physicians Lead on your favorite podcast platform or visit healthpodcastnetwork.com.
Hi, I'm Dr. Raj Sundar, a family physician and a community organizer. You're listening to Healthcare for Humans, the show dedicated to educating you on how to care for culturally diverse communities so you can be a better healer. This is about everything that you wish you knew to really care for the person in front of you, not just a body system. Let's learn together. Imagine being a patient seeking help and compassion, only to be met with denigrating and unkind healthcare workers. Because you didn't know, but your chart has clouded their opinion of you, even before they've met you. Because your chart is littered with words like agitated, belligerent, or non-compliant. Recent studies published in Health Affairs and JAMA have exposed a disturbing reality. This happens a lot, and it happens specifically to a certain kind of patient. Black patients are significantly more likely to be described with stigmatizing language in the electronic health record compared to white patients. This research highlights the dangerous consequences of this I patient, a term that Abraham Verghese coined a long time ago about how we often evaluate the electronic patient, the chart, before we see the real person. And our perceptions of who patients were and who they're supposed to be with this electronic health record leads to labeling of marginalized patients with negative personality characteristics. This invariably leads to poor care and perpetuates health disparities. So as healthcare professionals, we have a responsibility to address this issue head on. That's why I'm excited to have Nazreen and Sarita from the National Resource Center for Refugees, Immigrants, and Migrants join us today. NRC RIM was established in October 2020 as part of the nation's COVID-19 response. But now they've expanded their reach and they support health departments and community organizations to do a lot more, including disseminating linguistically and culturally appropriate health education resources through a rigorous translation process. Check out their website at nrcrim.org. Nazreen and Sarita are experts in using language as a powerful tool for promoting health equity. And I had the pleasure of meeting them at the North American Refugee Health Conference, an incredible event that we covered in episodes 25 through 28 of this podcast. If you haven't heard it, go check it out because it has keynotes and a reflection about how amazing that conference was. But the thing was, I missed Nazreen and Sarita's presentation at the conference. But I met a few people who were blown away by it and talked about how much it changed their approach. This episode was an opportunity for me to learn what I missed and share it with you. And I hope you have the same experience because I did. Nazreen and Sarita understand that in our desire to advocate for change in big systems, we often forget about our own spheres of influence. I frequently reflect on what I can do right where I am to help improve outcomes for patients who have endured tremendous trauma and displacement that no one individual can reverse or cure. And I mean it when I say this too. Something as simple as language, the words and terms we use, can make a significant difference in this context. There's definitely an individual lens to it, how we perpetuate biases, especially in the chart, and how we communicate about patients. But even more, language is important in how we talk about entire communities. Because we have to tell patients whole stories, acknowledging both the challenges that patients and communities face, but we must also highlight the strengths, wisdom, and expertise of communities. We have to avoid deficit-based narratives. Communities only need things, lack things. And then we go down this cycle of not even including the community members as partners in identifying solutions. We need to stop all of that. As you listen to our conversation, I encourage you to reflect on your own language choices and biases. Consider how you can use language to uplift and empower your patients rather than perpetuate stereotypes and disparities, which we do a lot right now. Let's dive in and learn from Nazreen and Sarita's expertise. And if you're interested in hearing more incredible presentations like this and meeting mission-driven, passionate people in the field, check out the North American Refugee Health Conference this year, happening August 5th through 7th in Minneapolis. It's an event you really don't want to miss. Go to refugeesociety.org or check out the show notes to sign up. Okay, here we go. Okay, welcome to the show. How are you all doing today?
I'm just fine. How are you, Raj?
I'm good. Before we get started, can you tell me a little bit about yourself, Nazreen and Sarita?
Hi, I'm Nasreen Quadri. I use she, her pronouns. My training is in internal medicine and pediatrics, and I've been fortunate to be building a career around the global local context. What I mean by that is caring for and being curious about healthcare issues that affect people that are either born around the world and come to the United States or also carry these ancestral histories of coming from many places around the world. And so my family immigrated to the United States from India. So I carry that story, that history, and that passion that fuels my interest in this field.
My name is Sarita Wilkins. I use she, her pronouns, and I am the communications strategist for the National Resource Center for Refugees, Immigrants, and Migrants, or NRC-RIM. And in that role, I manage the communications for the center itself, as well as lead our health education and health communications portfolio. And NRC-RIM is funded by the CDC and housed with the University of Minnesota. And we exist to support health departments and community-based organizations with their public health response in immigrant and refugee communities. I work with Nasreen. She's one of our physician collaborators at NRC-RIM, and she and I have a shared passion for language justice and language access and really focusing on the assets that different immigrant and refugee communities have and what they can bring to public health and medicine.
Thank you. Yeah, I've been excited to talk to you all about this for a while. Because I missed your presentation at the conference, and then I heard people walking out saying how amazed they were. And then I looked at your slides and it was beautifully designed. But I think the crux of your presentations were about language justice and how it can influence how we think about and value people. I think it's especially relevant and salient when we're talking about caring for refugees, immigrants, and asylum seekers. First, I want to expound on that idea about how do you think language affects people's opinion and why that's important?
We had a slide at the beginning of our presentation, and Sarita said it pretty well, that the presentation is not about how to be politically correct, right? That's not what we're teaching people about necessarily, but it's really about acknowledging that you can help people understand each other's humanity by choosing affirming language, right? So it's what we've discussed quite a bit is that terminology itself and what we choose as preferred language in society can certainly change over time. So it's not about memorizing and saying, okay, this means this, and this is what it's going to be every single time. But if we're really centering ourselves around trying to use language as a tool to express this respect that I have for you, that can be the common thread. And what we hope to help with is decreasing the fear around needing to know every single scenario, rather coming from a place of humility. How can I ask questions to understand how my use of this language or this term can impact you and your personal identities in the ways that it intersects together? Then that can really broaden our perspective of how to use language best. So our goal, of course, with featuring the power of language justice, if you will, is reframing that fear of being correct with the curiosity of understanding both the application and the implication of language when we apply it to individual people and then the communities that they come from.
Yeah, and just to echo on that, we of course say this isn't about being politically correct. There are a lot of organizations that are already doing great work in that area. The American Medical Association and others, the CDC have glossaries and other tools that you can use to make sure that you're using affirming language. My favorite one is called the Diversity Style Guide, and it explains a lot of the nuances of language that you might want to learn about. Language as a structural determinant of health or a social determinant of health. You're usually talking about language access. Is your health education written in a way that's simple and easy to understand? Are the translation and interpretation services available? It could even extend to whether patients are having culturally relevant experiences in health systems. And obviously, these are questions that are crucially important to consider. But it's also true that the way we talk about immigrant and refugee communities and patients influences their health outcomes. So when you humanize patients, they're going to have better health outcomes. When you talk about them with dignity and respect, even when they're not in the room, it affects how you interact with them. And when you make meaningful connections with patients, it makes a huge difference. And so, one of the things that I always advocate for is being more respectful by using that asset based language. For example, we sometimes will talk about communities being illiterate or even pre-literate rather than talking about them, for example, having a rich oral tradition and celebrating that. We refer to patients or communities as having limited English proficiency instead of talking to them as somebody who speaks languages other than English. We might say that a patient is at high risk for diabetes, for example, based on their certain socioeconomic factors, when really we could talk about they're disproportionately experiencing these poor health outcomes because of external factors that are outside of their control. Were we going to talk about a hard to reach community, or are we going to talk about a community that benefits from innovative approaches? And this is important because studies have shown that changing how people talk changes how they think. Teaching people new color words, for example, changes their ability to discriminate colors. And teaching people a new way of talking about time, gives them a new way of thinking about it. And I need to give credit to Dr. Lyra Boroditsky. She's a brilliant author and public speaker who talks a lot about how language shapes the way you think.
Yeah, I think I resonate with all of that. It's like with my kids when I'm trying to teach them words and they said, why is it that way? And if I want to say that's just how it is, I know I'm going into some conditioned form of understanding that I need to challenge myself or have a good explanation of. I think in healthcare, it happens a lot because it starts in training, in medical school, in residency, and then there's a process of acculturation. I think, Sarita, as you talked about, and I think in the presentation, it calls out how that language can ultimately determine how we identify what the problems are, one, and what kind of solutions or interventions we seek. Because if we blame the patients for having limited English proficiency, do we just need an ESL class in our clinic? Then they can fit in and understand what we're trying to say versus, hey, they have these beautiful languages that have rich oral traditions. What does it mean to communicate in the way that resonates with them? And that you go down a different path. And I'm just imagining a leadership meeting where the language use essentially affects what is done ultimately with the funding that we all talk about.
Absolutely. I'd love to jump in on that clinician angle there a little bit, because for clinicians in those individual encounters with their patients, the bias and the language that we have the power to choose is often directly documented and then attached to that patient for their ongoing care during that encounter and then several encounters into the future. And often we have talked about health disparities over and over again. We've been documenting them for decades at this point. We certainly don't want to be naive, and we know that the reasons for these health inequities existing are super complex and quite multifactorial. What I keep focusing on is what if there is something within our sphere of influence as clinicians that we can control and improve on, and what if that action in itself can shape health outcomes and improve them? And as you were mentioning, one of the examples is stigmatizing language, and the patterns of how we use that language and the attitudes that are implied based on that are certainly not evenly distributed amongst all patients. Rather, they tend to be used quite a bit when describing marginalized communities. And so in our presentation, there was a couple of really profound examples that we found. So one was a qualitative research study that was in JAMA Network Open. It was published in 2021, and it looked at 600 different physician notes from 130 or so different physicians, and they categorized how language was documented to express both positive and negative attitudes. And they were able to create qualitative themes around that. And so one important way that we convey our negative attitudes when we are having them in patient care is through questioning that patient's credibility. And so we might document that as patient claims X, Y, or Z thing, or supposedly had this thing happen, or the patient is insisting, which is very clearly communicating our sense of doubt and the validity of what that person is saying and whether or not it's true. And then on the flip side, when we think about, okay, how can we document positive attitudes? What is that language choice? And so it's quite the opposite here. It's minimizing blame. And for example, say a patient, you made a plan together at a previous visit, and this was a treatment plan to take this medication. Minimizing blame would be the approach to understanding maybe the reasons why someone might not adhere to the plan that was made at a previous visit, and then choosing to use that language in documenting that discussion and saying this person was unable to take this medication for this reason. It feels like it offers that opportunity or like the possibility of documenting why a reasonable person might make this choice in this really complicated, difficult world that we live in. And we have this conscious choice of what we choose to document, how we document it, who it's applied to. And those exact words, I think, convey a lot more than maybe what we were trained to consider. And oftentimes these patterns of language are just the same things that I learned as a medical student, as a resident, etc. The other piece here, though, is how far this negative stigmatizing language can reach. Another study has actually documented how those negative stigmatizing words are used more often towards Black and Latino patients, 2.5 times more likely for Black patients to have negative stigmatizing language in their history and physical notes, and 1.5 times for Latino patients. And they reach as far back into training. Where do we learn these patterns? Where do we learn these norms? So much so that when they have surveyed medical students, nearly half of them in one study had been exposed to negative comments about Black patients. And that in itself has changed their implicit bias compared to year one when they came into a program. By year 4, they had increased anti-Black racial bias as a relationship to these exposures to negative comments.
Also probably challenging our medical school curriculum and that paradigm. I also want to appreciate, Nazreen, I think it was a concrete example of what it means to lead with humility and empathy when you are detailing the actual reason somebody didn't take a medication versus taking it easy out and saying they were non-compliant. Which I think there's been more and more conversation just about that terminology and all the power structure implied there, but actually detailing what had happened. I wonder, in your experience, how do you approach challenging situations when there is a disagreement? And a common, I think, a situation that I hear and I come across too is, for example, the antibiotic use for someone who is sick with probably a virus. And because wherever they're from didn't have a robust healthcare system, the expectation was you go in when you're sick and often you get an antibiotic. So those expectations are transferred to an American healthcare system where we want to minimize antibiotics and talk about preventive screening. And there's real, I think, gap in understanding of what healthcare is and what health means. I think that's sometimes a tricky situation where I also see some of like patient declines going to get breast cancer screening because she doesn't believe in it. So I think your bias comes out, and even if you don't intend to. So what do you think about those situations, and how do you approach it with the same principles that you just brought up in your?
Great question. I think it's part of the training around providing care with cultural humility in mind, especially when having patients that speak a breadth of different languages and see the world in such different ways. It's helpful to just start from their own framework, right? There's no universal framework of what healthcare is and what being well is. And that's why language in itself is so embedded into our beliefs around what do I need to do to keep myself healthy and same for my family? And what do I believe is a true disease process? So often I think going to that place of what do you think is going on with your body? What do you think is causing it? And what do you think would help you? I think that taps into some of the answers that we otherwise would assume. We would assume, oh gosh, this person maybe has had this experience and that's why they think that. But that may or may not be true. And without directly asking them for more input around their frame of reference and what they've experienced and how they process it, what they're coming into that encounter with, it's hard to move forward from there.
Yeah, that makes sense. Sarita, do you feel like, going back to what you were also bringing in about the importance of language of population, stepping back from the clinician perspective, I think I sometimes struggle with how different communities can self-elect to call themselves differently, whether there are small tribal communities within larger communities that don't want to be identified as the country of choice. Like it could be the Ethiopian community having conflict with the Tigranian community. So no, I'm not Ethiopian, I'm Tigranian, right? And this complexity around, I think one part of that you mentioned is this political correctness. People don't want to get it wrong, especially with discussion of racism. But the second is just getting it wrong and offending someone. So people have a hard time even committing to something. And then they step away from the conversation itself. So how do you feel like we need to approach it?
That is a great question. And I think some of the resources that I brought up previously are going to be really helpful. And the diversity style guide that I mentioned, they have an entry. This is an example I always go to about Latinx versus Latino when describing somebody from a Latin American community and which you should use. And the diversity style guide in this example cautions against using the word Latinx, even though I'm seeing it more in social media and in different cultural aspects, because Pew Research actually did a poll, and I want to say something like only 3% of Latino people actually use that word to describe themselves. And whenever possible, you should use the word that somebody would use to describe themselves, whether it's Latino or maybe it is Latinx for a specific person, and trying to use that word as much as possible, including when they're not in the room. And the way that I think it's really helpful to think about it as not if you're going to make a mistake, but when you're going to make a mistake, because you are going to make a mistake. And so how are you going to react in that moment? And really practicing that, making sure that you are apologizing and you're correcting, but you're not putting so much self-blame on yourself that the other person in the room is compelled to console you for having made this grave mistake, and being able to learn from it. Calling somebody Tigrinya instead of Ethiopian, if that's what they would like to be called, then that's what they should be called. And having that humility when asking the patient or asking the other person you're working with for their advice about how to describe themselves. And it really connects with what Nasreen was just saying. She's saying, ask the patient, what do you think is going on with your body? And what do you think would help? It's the same thing where you're asking the patient or you're asking the person that you're talking to about their identity and how they would describe it, and then using those same words.
Well articulated. I love it. What I sometimes struggle with is where's the balance between meeting people where they're at versus education? Because one thing that happens is when we do intake, we've been attempting to be more inclusive of all genders and expressions of genders. And I think with certain refugee communities, if you're talking about pronouns, first, in some communities, especially if there's a religious component to it, they don't want to answer, or they don't feel like their kids should answer. There's a lot of steps, and they feel like in order to meet them where they're at, we shouldn't be talking about gender as fluid. And the question going back to is, hey, we're trying to be inclusive for the LGBTQ plus community, which we know are part of even the most Orthodox refugee communities. There are folks in there. We want to be inclusive, but the general norm in that community is not accepting it.
Yeah. So I will start. And what I'm going to say is that we have a guide on our website for translating and culturally adapting sexual orientation, and gender identity questions for the purposes of contact tracing. I would be happy to send that to you.
I don't think it's an either or. I think that we can create these like really inclusive spaces in healthcare that allows the opportunity for people to be fully themselves, and then also have an option if you don't feel comfortable answering that question, that's okay too. And that way it doesn't take that away, and it doesn't necessarily put maybe two different marginalized communities against each other, because I don't think that's the truth. And as you highlighted, these intersections are really important. The LGBTQ plus community is marginalized and persecuted in many places around the world. And that could be the reason for migrating to the United States amongst other places. And so how do we keep that conversation open to allow somebody to identify for themselves what is an important thing? Hey, as my clinician, I want you to know that these factors of the society around me are affecting me, and you won't know unless you're given that opportunity. I think just making the space for it is important.
Yeah. Thank you. With language, what does it mean to advocate for policy changes? We often say, oh, this is just what's required. So we have to step back into that area. I'm sure you all are doing that work, but what does it look like, and what spaces do we need to be advocating for change in order to make it a reality in all of our communication?
I'll speak to the research to back the policy first, because often before you can have policy changes, they say, show me the money, show me the proof that it's needed. And research through NRC RIM tends to focus on language as a key exposure. And so we did research that was published last year about COVID-19 vaccination and who necessarily had access to the vaccine and who was able to receive it, and during the pandemic, and how might that have related to the outcomes that we saw around hospitalization and death. And so not surprisingly, when we ask different questions, we get a rich set of results that opens up this problem broader. So I think we are fortunate to have a lot of documented research around racial and ethnic disparities, which is really important for documenting racism, systemic racism, and the access to these therapeutics and vaccinations. And so in shifting that conversation just slightly, we decided to look at the languages spoken. And of course, what we found is people that speak languages other than English had a delayed opportunity to receive that vaccine. And that was correlated with poorer clinical outcomes, meaning hospitalization and death. And what's exciting about that research is the opportunity to do something to intervene on what we found, which would be creating solutions that really allow for health information to get out to the community in the ways that are valuable. And that's what we do at NRC RIM. It's fun to think of solutions outside of the clinic walls, outside of the hospital walls, and to get information through different trusted messengers, through different avenues, not necessarily just written, sometimes video PSAs, audio PSAs, in-person meetings in safe places, just really seeing health outside of these closed-walled institutions. So the research part is a big piece that would, I think, lead towards policy and advocacy.
Yeah, I think I remember that part of your slides. I'm glad, as you said, you have that data to support policy changes, which is so important because people want that data.
And sometimes we can frame it as, people who spoke languages other than English were more likely to delay getting their vaccine, putting the blame on the patient themselves of saying, there's something specific to this culture, this language, or this population, which then caused the end result. Instead of really shifting that language to say, folks who spoke languages other than English were more likely to experience delays in vaccination, which does shift the blame a little bit to the system and make us question, I wonder why that was. Were we getting information about vaccine availability out to the community in their own language? Were they the ones that knew where the first vaccine centers were going to be? Were those places close by where they live? Was transportation an issue? All of those different factors speaks to how language can be utilized to blame kind of different groups or understanding it more systematically.
And just to add on, that's a really great point, Nasreen. But when you are shifting the blame from the patient to the system, remember back what I said about how when you teach people different color words, they're able to see colors differently. When you teach people to take the blame away from the patient and putting it instead on the system, think of how they're going to think about their patients. Like, how are they going to interact with their patients differently? How are they going to interact with their systems differently? How are they going to advocate for those policy changes? And so it's just a little thing about rather then they delayed their vaccination versus experienced delays. It's a very slight change in language, but it can make a huge difference in how you see and interact with the world.
Yeah, I appreciate both of those answers. I think one piece that we haven't fully talked about, and I'd love to hear about some of the solutions. I think one of your recommendations or thoughts was about telling a patient's whole story. What does that mean to you all, and how has that manifested for you in your life?
Yeah. So my recommendation from a public health perspective or from a communications perspective, a person can be an immigrant or a refugee, and they can be subject to forced displacement. They can have language barriers, they can have histories of trauma, and they can have complicated health profiles, right? Don't sugarcoat this. Don't pretend like it's not there. But the point is that you can't forget that they are also our neighbors and our friends and they're business owners and entrepreneurs and their parents and grandparents and artists and musicians. And they care for the sick and elderly. They bring food to our stores. They educate children. They pursue their own education. And the point I'm trying to make is that immigrants and refugees have the wisdom, expertise, and desire to influence health systems to serve their communities better. And they are deserving of your partnership. So don't talk about the deficits without also talking about the strengths. Don't talk about the problems without also identifying solutions. This is going to change the way you think, and it's going to change the success of any public health campaign or any communications effort that you're doing. Just telling that patient's whole story is so important.
And so much easier to do when people have a seat at the table, right? Because then we're not talking about an other that doesn't exist. We're talking with people that are truly representative of that community experience and thinking together towards those solutions. But I have one comment around solutions specific for clinicians in regards to bias. We didn't get a chance to touch on it. Where do we learn this bias? Bias comes in to our consciousness from so many different places, including media exposure, which I think is really fascinating. And so certainly there's been smart researchers out there asking this question from a clinical psychology lens of how do we study what impact exposure to this media source can have in determining my attitudes, for example, around immigration. And so there was this really interesting study that was published in 2019 in the Frontiers of Psychology journal, and it was titled, "Are You What You Read? Predicting Implicit Attitudes to Immigration Based on These Linguistic Distributional Cues from Newspaper Readership." And as we know from being exposed to media right now too, there are certain outlets that might be leaning one way or another. And so in this study, they looked at two different newspapers that had two different leanings towards immigration. One was pro-immigration, one was anti-immigration for the most part. And what they did is they created an implicit association test around immigration, similar to a lot of other kind of biased attitudes, and did find that bias both for and against immigration was related to the messaging of the newspaper. So this media exposure surrounds us all the time, and therefore none of us are really immune to that influence. And it's so fascinating that they were able to conclude that exposure to biased language contributes to biased implicit attitudes. And so without studying that and acknowledging it, it's hard for us to pause and say, oh gosh, I wonder what the influence of this exposure is going to have and what's going to be the downstream effect of that. So I mention that in the sense of for clinicians, we can study that experience and the interactions we have with our patients with a kind of a similar scientific lens to it. So there's this group, I believe it's out of the University of California, San Diego and the University of Washington. And they created this category of tools that they named unbiased. They're specific tools that capture audio content from patient-clinician encounters and then code specific things, social signals, talk time, interruptions, conversational turn taking, and pauses. And then you can analyze those factors, those signals, and then present it back to clinicians for an awareness of how their own bias might show up in their encounter with different types of patients. So I think it's fascinating just to think about how we can innovate and use technology for our own benefit and make that hidden bias, that hidden curriculum more visible as long as we have an intention to then address it as well.
Yeah, it's about awareness and taking that next action step. But it's so great to hear about all these tools and resources, and seems like a clear change in the curriculum that we need with these conversations and communication, which I think is really undervalued in our education about what it means to care for people, because we still are towards so much about the scientific and medical part of it and not the humanity part of it. So I think that's a good and important point to make. Any other takeaways that we didn't cover from your presentation or the work that you've done, or what are you working on with language and what's next step for you?
One thing that I wanted to point out, that an important thing to remember is the value of community partnerships. Having somebody at the table who's from the community, and how can they inform your policy? How can they inform your work? Because we too often underestimate the expertise that exists within communities and their willingness to participate to influence those systems. And so I just would definitely recommend, if you work for a health system or a public health department and you don't already have established partnerships with communities of color or Indigenous communities in your area, that you seek those out.
I don't have necessarily anything to add to this current content, but what you were asking about, what are we working on? What's the next frontier? But we're really, hoping to continue to expound on this idea as language spoken as its own independent, standalone variable. And I think the wealth of knowledge that can come from assessing that in different clinical scenarios. So whether that's who received different COVID vaccines, who received different COVID treatments, especially early on. I think there's so much that's there because it helps us to pause and say, gosh, what was the process? How well prepared were we to be talking about novel medications that were new to us, new to the scientific community, had a lot of ongoing research data that was coming in real time? And how much should we think about how well that would translate when we're speaking to patients with several different languages? And then how do we capture that and how do we research it? So that's an area of interest right now, but even thinking of more common kind of clinical parameters around maybe sepsis treatment in hospital, what are those language-based disparities? And then how do we broadly think about addressing them? And it may not just be, again, inside of our own walls, right? If we learn that there are gaps in our shared understanding of certain disease processes, then those partnerships really matter. You can go outside of clinics and hospitals and start working with community-based organizations around individual issues.
Yeah, thank you. I think both of your comments now and a few minutes ago reminds me of one of the takeaways with your presentation of knowing yourself and knowing your field. Both are fundamentally reflection-based practices, which often we lack in healthcare, either because of burnout, feel like we're in a treadmill, or we're so conditioned to be part of this system. But reflecting on knowing yourself in those conversations, how does bias come in, and knowing your field or where these gaps are, and what does it mean from your position to make change, whether that's research, policy, advocacy, or individually treating your patients better now that you understand that better, I think is really important.
Just to echo that, even what can you individually do, even if you're not in a position to influence policy, the language that you use affects others too. As Nasreen was saying, exposure to certain newspapers, or we talked earlier about medical students, and something like 49% of them were exposed to negative descriptors about Black people. The things that we hear in our day-to-day matter, and they shape our perspective. And so by training yourself to use more affirming language, you are going to be able to make a difference in your workplace and your communities as well.
Thank you. The last question that I often ask is about your individual experience of you getting care or your family getting care. Have you noticed when things have gone especially well or wrong with the topic of language, if you're willing to share about what that looked like?
I will say, largely growing up, English was still the predominant language, despite being bilingual at home. But I think about those healthcare encounters where you have that language concordance. I think we still have this very narrow spectrum about thinking about language, right? Of in a very translation sense of, I say this, now you say this in this language. But I think there's so much that's conveyed when you are aware of all the different parts of language and culture and what this means and how you say it, etc. So I will say, as an attending now, it's been just such a joy to see when my trainees are speaking the same language, have the same spoken language preference as their patients, and how that totally changes the demeanor and the encounter and the ability for trust building. So in that way, I have a lot of hope and excitement for the field of medicine, because I think these are all not just like theoretical or research questions. I think they have true real world application. And the more that we are focused on it, and the more we're bringing it into our educational awareness of trainees and students, I think we can see it in practice, and we can empower people to take on those opportunities. Because I'll say in an opportunity like that, previously, maybe that trainee would not have felt like, oh, is it my place to be speaking my language with the patient? What if everyone else can't understand, that kind of thing? But how do we empower that and say, no, this is above and beyond. This is amazing. We should encourage it. We should help in all the ways that we can improve the language.
That was such a good answer. It's hard to follow up. I guess what I'll say, I know your listeners cannot see me, so I'll describe myself. I am a light-skinned Black woman, and I have had people make certain assumptions about me. For example, that I don't speak English, or in healthcare settings, make assumptions about the cause of why I'm going to the doctor. And I'll just say that those assumptions, are often not true. And I think that it's important for folks to question their own assumptions that they have about their patients and keep an open mind about who they may be working with and the different and various experiences that they may have had when approaching any patient interaction.
Thanks. I know it's hard to reflect and think about those experiences, especially if they've happened multiple times, but it is an important point. I think really taking time to consider how individual clinicians are biased and how much it sticks with you for a long time. I think over time, the more encounters you have like that, the skepticism and the distrust over healthcare system happens. Going back to your point of, hey, it's so important, even if you don't have power, for individuals to make these changes because it affects and it matters for your patients. Thank you so much. I learned a lot, and I will totally be there at your TED conference when you're invited and talking about this. Okay, Sarita and Nazreen, where can we find you online and in person next?
You can find us online at nrcrim.org. We would love to hear from you. We're also on Facebook and Twitter.
And then in person, we hope to see many folks, including you, Raj, here in town in Minneapolis this August. The North American Refugee Health Conference will be hosted right in our backyard here in the Twin Cities, August 5th through 7th. We can't wait to host you.
I'm looking forward to seeing you, Raj.
Thanks again, everyone, for joining me on another episode of Healthcare for Humans. If you liked this episode, as always, my ask to you is please share it with one other person and go to healthcareforhumans.org to sign up to be part of the community. I'll see you next time.